Hello guys, this is Dr. Asif. So welcome to my channel, that is Medical Treatment Surgical Classroom. Let's discuss about a long case which is called the benign enlargement of prostate, which is also called prostatic enlargement due to BPH or benign prostatic hyperplasia. This is its anatomical name. So it's a very common long case which is discussed all over the world, and it is very important long case which is invariably asked in the exam and also given to the post graduation finals. So let's start. First, you have to make a salient feature. That means you need to describe your long case within 5 to 10 minutes with very politely and also clearly, and you must not look into your patients, rather than you have to look to your teachers, and you have to explain a full long case with full of confidence. Okay, so my patient Mr. X, 65 years old, normotensive, non-diabetic businessman, hailing from Shonadanga, Khulna, presented with the complaints of increased frequency and urgency during the act of urination for 1 year, difficulties during the act of urination for 9 months, and sudden stoppage of urine passage for 10 days back. According to the patient's statement, these presenting complaints started about 1 year back. Then he developed increased frequency during micturition, both day and night initially, 7 to 8 times per day and 4 to 5 times per night, but for the last 2 months it is about 10 to 12 times per day and 6 to 7 times per night. He also developed urgency and urge incontinence. He had to wake up from sleep at night due to increased frequency. He also noticed difficulties during micturition for last 9 months in the form of port stream, not improved by straining, rather stop, associated with hesitancy and non-continuous flow and prolonged terminal dribbling with sense of incomplete evacuations. He's developed acute retention of urine with pain in lower abdomen for about 10 days back and needed to the hospitalizations and relieved by catheterizations. So this patient come with acute retention and this bowel habit is normal. The second part is he has no history of hematuria, pyuria or any trauma or any instrumentations through urinary tract and no features of metastasis. He has no significant past history, but he takes alpha blocker for about 9 months. He has no history of allergy or any foods or drugs. He is immunized. He is married, having 3 children, all are healthy. He belongs to middle class family. He is non-smoker, non-alcoholic, non-betel nut chewer. On examination, he is no anemic, non-ecteric, not dehydrated. Nutritional status is average, and all other vitals are within normal limit. On genitourinary examinations, there is a 16 French Follis catheter in situ, penis, scrotum and external urethra meatus, anterior urethra are normal, testis, epididymis and vas are normal, no suprapubic fullness or tenderness, kidney not ballotable, renal angles are non-tender, abdominal examination reveals normal except digital rectal examination shows prostate enlarged in size, surface smooth, firm in consistency, central sulcus prominent, upper limit cannot be reached, and central mucosa is free, not fixed with underlying structure, and on withdrawal of the finger, it is not blood stained. Other systemic investigation reveals no abnormality. So this is about salient feature. So above all the explanations, what is your findings? That means your probable diagnosis should be benign enlargement of prostate. What are the other possibilities? It should be carcinoma prostate, urethral stricture, bladder outlet obstruction, that is bladder neck hypertrophy, neurogenic bladder, and infection lastly, which should be in the bladder or prostate. Okay, now what investigation you should perform? It's a $1 million question in this case. So firstly, you must do investigation in 3 manners. Like, some investigation you must perform for routine checkup, and some investigation for diagnostic workup, and few investigations should be watch out your fitness of the patient regarding surgery. So CBC, complete blood count, serum creatinine, RBS or rapid random blood sugar, serum electrolyte, urine for RME, USG of whole abdomen with special attention to prostate and uroflowmetry, urodynamic study, IVU, intravenous urography, cystourethropy, transrectal ultrasound, and serum prostatic specific antigen, which is done to exclude prostatic malignancy. Normal is 3 to 4 nanogram per ml, which is not more than 10 nanogram per ml. If it is occurs more than 10, it should be suspicious that there may be a tumor which may be benign or malignant. But if the PSA is more than 35 nanogram per ml, it is advanced disease, or prostatic malignancy may be it is already advanced to surrounding organ, also the bones or spine. Now, what is uroflowmetry, which is important test to know or assess the patient might have BEP. So it is meaningful that 2 to 3 voids should be recorded using a special flow meter, usually found in the urology outpatient department. And what is urodynamic study? The key to the practical management of lower urinary tract dysfunctions, particularly incontinence. In case of incontinence, we usually do urodynamic study. Lies with urodynamic investigation. The principle is to artificially stimulate bladder flaring and emptying while obtaining pressure measurements. Okay. Now, is there any role in intravenous urography in BPH? Yes. An IVU provides information about upper tract as well as the degree of residual urine, looking of the lower ureter or elevation of the bladder base, suggested marked intravesical prostatic enlargement. Plain X-ray, KUB, ultrasound can show all the findings of an IVU. So IVU is dye dependent, and it's one kind of invasive procedure because some patient might have kidney disease or CKD or advanced renal disease. In that case, you will have an alternative, that is X-ray, KUB, and ultrasound, which will give you the same information like in IVU. So IVU is good, but I think it is costly and time consuming. Also it will give some extra stress to kidney. In that case, plain X-ray, KUB, and ultrasound can be done as far as I know. So what is the indications of cystourethropy? So high IPSS, International Prostatic Symptom Score, which is newly developed a scoring system by which we can divide the patients with different severity. And also there should be hematuria and hydrourethronephrosis in ultrasound scan. Okay, so if these 3 symptoms like high IPSS, and if there is evidence of hematuria and also the hydrourethronephrosis in ultrasound scan, then definitely cystourethropy should be done. What are the indications of transrectal ultrasound? And if in case of PSA is high, age over 65, and also prior to prostatic biopsy. Sometimes transrectal ultrasound guided biopsy can be done for BPH or taking prostatic biopsy. So sometimes we can perform, but there should be a contraindication, or there should be a disadvantage where during you take from biopsy from prostate, sometimes malignant tissue deposition can be occurred in the rectum, because it is done through rectum and a needle pass through the rectum to the prostate. In that case, some tissue may be accumulated in the rectal wall during prostatic biopsy. So I think it's not wise, but if the patient's age is more than 65 and radical prostatectomy is not possible, in that case we have to take biopsy, and also we can give targeted radiotherapy as a palliative treatment. Now, how will you treat the case? So after confirmation of the diagnosis, patient should be counseled about the disease and treatment protocol and prognosis. And if, as the patient presents with acute retention of urine followed by catheterizations, if the patient is fit for surgery, I will advise prostatectomy. So as a patient presents with acute retention of urine followed by catheterizations, and if surgery, then prostatectomy. This is the main treatment in short. So what are the factors that should be considered while selecting the treatment options in BPH? So some few factors like age of the patient, symptom score of the patient, DRE findings, ultrasonography findings, uroflowmetry findings, serum PSA level, and complications which is pre-existing from the admission. That means complication if that is arised due to late coming or already a late case. In that case, these factors should be considered accordingly, I think. So what are the absolute indications for prostatectomy? So acute retention, it is first and foremost indications where treatment is surgery, and no other cause like retention like drugs and constipation and recent operation. Okay, you have to exclude these things, like patient is not taking any drugs which can cause retention, also constipation and recent operation. So chronic retention and renal impairment. So residual urine will be 200 ml or more, and raised blood urea, hydroureter or hydronephrosis, and uremic manifestations. Complications of bladder outflow obstruction, stone infection and diverticulum formation, hemorrhage, venous bleeding from ruptured vein overlying the prostate. Elective prostatectomy for severe symptoms, increasing difficulty in micturition with considerable frequency day and night, delay in the starting and poor stream are the usual symptoms for which prostatectomy is advised. Severe symptoms, a low maximum flow rate less than 10 ml per second, and also increased residual volume of urine 100 to 250 ml are relatively strong indications for operative treatment. So these are the symptoms. If the LUTS or lower urinary tract symptom is more prominent, and there is evidence of retention, and also the urodynamic study is less than 10 ml per second, and also the urine that is post vital residue PVR is more than 200 or 250 ml, in that case we should go for surgery. So what are the options for treatment of LUTS secondary to BPH? The conservative measures should watchful waiting in conjunction with fluid restriction and reduction in caffeine intake, and drug therapy is alpha blocker or in men with a large prostate 5 alpha reductase inhibitor or both, or which is also called finasteride in our country or all over the world, which is called finasteride solutions, which act as a 5 alpha reductase inhibitor with alpha blockers. So interventional measures include transrectal resections of the prostate, that is TURP operation, which remains the gold standard, and holmium laser inoculations of the prostate, HOLP, and other options of prostatectomy. Those the laser holmium laser inoculation is the newest treatment protocol, and which is not ideal still now, but yet in the experimental phases. But soon we will know the complications or outcome after the laser operation in this case. So I think you should know the naming only, that it is also been coming in your futures. Okay, when will you consider for watchful waiting? In men with the symptoms scores if 0 to 7 and reasonable flow rate more than 10 ml per second, and the good bladder emptying or residual urine is less than 100 ml. That means we should go for medicational treatment rather than surgery, so we can wait for a while. So what are the medical treatment of BPH? So two different strategies have been attempted to treat the BPH with pharmacological manipulations. Suppression of androgen stimulation of prostate growth, like anastrozole solution or androgen or testicular hormone preventive medications act as a chemotherapy for reduction of prostatic growth. Inhibition of sympathetic tone in the prostate and bladder neck, and endocrine manipulation by 5-alpha reductase inhibitor, which is also called finasteride, I already mentioned, and the selective alpha blocker, that is temsulosine. What are the side effects of alpha blockers? So for a prolonged use of alpha blocker, you will encounter postural hypotension, retrograde ejaculation, and dizziness, yes, and tired headache. So what it should be? Retrograde ejaculations, dizziness, tiredness, and headache. Okay. So what are the complications of 5-alpha reductase inhibitors? That is the reduced libido, decreased ejaculate volume, and a masking of CA prostate. So it will act as a like a symptom like CA prostate, but ejaculation volume will be reduced and reduced libido. Some of the medicine professors and also dermatologists suggest finasteride solution orally for pre-treatment of androgenic alopecia, but during that process these symptoms may arise. So I think finasteride solution should be taken after completing family or after having 1 to 2 children. I think it will give a long term side effect if you take it as a 5 to 10 years because of prevention of androgenic alopecia. So I think you should go for tropical 5-alpha reductase inhibitor rather than oral intake. Okay, so I think that will be very helpful. So what are the points you will consider during follow-up of the patient with medical treatment? So patients on medical treatment should undergo regular follow-up program at 3 months interval. The following points should be carefully observed, that is symptom score, bladder and renal ultrasound scan, uroflowmetry, whether the patient is developing any other complications during treatment or not. So what are the complications of prostatectomy? It is a very fundamental question for written, but sometimes if you already passed, so your teacher can hammer you that for giving you the good score. So in that case this question can be asked, that what are the complications. So there are some local complications, preoperative complications, early postoperative, and late postoperative complications. So local complications should be infection or delayed wound healing and retrograde ejaculation. These are the complications. And the perioperative hemorrhage, injury to the bladder, urethra and sphincter, and also early postoperative complications should be reactionary hemorrhage for the first, clot formation and retention, secondary hemorrhage, wound infection, incontinence, and late postoperative complications should be retrograde ejaculation, impotency, and urethral stricture. If overcut or if an injury to the urethra, there in that case postoperative lately there should be a rise with urethral strictures. So what are the methods of performing prostatectomy? So there are a few methods which is popular, and the among them the most important or popular one is the TURP operations, transurethral resection of prostate, retropubic prostatectomy, which is almost obsolete nowadays. Suprapubic or Millin's prostatectomy is only things which is practice, or intra-abdominal prostatectomy through the bladder, through the perineum, and new technique, holmium laser inoculation of the prostate, that is HOLP. Now, what is TUR syndrome or TUR syndrome? So absorption of water into the circulation at the time of transurethral resection can give rise to congestive cardiac failure and dilutional hyponatremia and the hemolysis. Accompanying this is frequently confused. The patient may given symptoms about confusion and other cerebral events like mimicking of the stroke. So this is invariably happen because after operation we usually irrigate the bladder through normal saline, and this TOR syndrome happens due to over irrigations. But nowadays we use glycine solutions which act as a preventive measure for TOR syndrome. Why important is developing TOR prostatectomy? The corpora of the penis gets autonomic innervation by neurovascular bundle that lies very close associations in the prostolateral aspect of the prostate capsule. So during TARP or prostatectomy, injury to this bundle occurs directly or by inadvertently use of diathermy. Okay. So why retrograde ejaculation occurs? So normally during ejaculation the sphincter closes to prevent retrograde ejaculation. After prostatectomy, retrograde ejaculation occurs because of injury to the internal sphincter that lies in the upper part of the prostate. So what do you mean by bladder outflow obstructions? This is the urodynamic concept based on the combination of the low flow rates in the presence of high voiding pressure, and it can be diagnosed by only pressure flow studies. The uroflow rates decrease volume less than 200 ml. A peak flow of more than 15 ml per second is normal, but when it is 10 to 15 ml per second or equivocal or less than 10, so it is considered as bladder outflow obstruction. So voiding pressure increases, water are high, and pressure between 60 to 80 centimeter are equivocal, and pressure less than 60 centimeter of water are normal. So what are the complications of bladder outflow obstructions? So due to bladder obstructions, it is very clear that acute retention, chronic retention, and impaired bladder emptying with development of urinary infection and calculi or stone formations, and its evidence should be act as a hematuria. So hematuria is very common in this case if there is a presence of any infection and calculi. Okay. So on the other hand, bleeding is not so frequent, but it comes from complication like infection and calculi. So what are the etiological factors of development of BPH? So the BPH is still unknown, the cause. The most current theories on etiology of BPH focus on hormonal imbalance, that is estrogen and androgen, or as yet undefined prostatic growth factors like fibroblast growth factors with a permissive role or hormonal involvement. Like no exact cause is known, and estrogen androgen is synergism, decrease apoptosis, and genetic factors. What are the risk factors of BPH? Age is important because after 40 the symptom of BPH is initially started, and which is more prominent after 70, 65 or 70, 75 years or later on. And availability of the dihydrotestosterone, okay, DHT, and the racial factors common in American black, and genetic factors in many run in families, and then diabetic mellitus, and the hypertension and cirrhosis of liver. So what are the effect of BPH? So due to bladder outflow obstruction, there are some changes that occurs proximally that should be occurs in the bladder, and some effect can be happened in the kidney ureter also. So in urethra, prostatic urethra is lengthened sometimes to twice as a normal in length, and normal prostatic curve may be exaggerated, that it requires a curved catheter to negotiate it. And in case of urinary bladder, if BPH occurs bladder outflow obstruction, the musculature of the bladder hypertrophies to overcome the obstructions and appears trabeculated. Significant BPH associated with increased blood flow and the resultant veins at the base of the bladder causes hematuria. Functional effect: the lower urinary tract symptoms, acute and chronic retention of urine, impaired bladder emptying causes urinary infections and calculi formation. So as you know, all the complications that UTI, trabeculation, diverticula formation in the bladder wall, retention of urine, hematuria, stone formation, back pressure, changes in the upper tract, and also the renal failure. So thank you. This is all about the long case of bladder outflow obstruction due to benign enlargement of prostate. It is very common in undergraduate level, but some PG examinations it is given, like MCPS or FCPS exam, and I don't know about the FRCS section 2 exam, but I hope it's a very common long cases on all over the world, and it is very common in the elderly age. So I think you should know for BPH thoroughly by watching my videos repeatedly, and I think it will be helpful for you. Please like and subscribe my channel and give me support so that I can give encouragement for making videos forward. Thank you.